like a box of chocolates. You never know what you're gonna get.
His symptoms include gradual onset of pain along the medial aspect of the lower leg and around the medial malleolus, increasing
that's
after
tender,
long
boy.
runs, pain during resisted inversion and single leg heel races,
Oh, that's tender.
a collapsed medial arch during gait observation, especially as fatigue sets in, and occasional reports of stiffness and aching in the arch after long periods of standing or walking. Go.
Oh,
Let's start palpating. First, we have the medial malleolus, which is right here, and this is the bony landmark that acts as a pulley system for the tendon, which curves tightly around it and is the point of maximal compression. It's also the most common site for posterior tibial tendinopathy. Next up, we have the navicular tuberosity, which is on the medial side of the foot, and this is the primary insert of the posterior tibialis, and this is where the tendons distally attaches and lifts to support the medial arch. In tendinopathy or dysfunction, this point may be painful, and the navicular may appear dropped because the tendon can no longer maintain the arch of the foot. Then you have the base of the first metatarsal, and this connection helps stabilize the medial column and controls the forefoot during push-off. And in the posterior tibialis, this segment often drifts into abduction as the tendon can no longer counter pronation forces. Medial border of the tibia, yes. If there's dysfunction higher up in the muscle belly, there's going to be tightness, weakness, or fascial reconstruction, and it can increase strain on the tendon distally. Proximally based tissues often coexist with the tendon's pathology near the ankle. Next up, you have the fibula, which is on the lateral side. Posterior surface of the fibula, there's a portion of the posterior tibialis, and it gives the muscle a broad base to pull. Next up is the calcaneus. Can you rotate your foot? The calcaneus. The posterior tibialis does not insert here, but it is strongly influenced by the position and of controlling the hindfoot inversion. If the tendon fails, the calcaneus collapses into valgus. This shift increases strain on the tendon and creates a cycle of accelerated tendinopathy. Next up is the Achilles tendon, which is right here. The Achilles tendon is besides the posterior tibialis, and it pulls directly upward on the calcaneus, and the Achilles primarily provides plantar flexion, which relies on the posterior tibialis to keep the heel from collapsing into valgus during loading. If the posterior tibialis is weak, the Achilles tendon pull becomes unbalanced, often worsening pronation and arch collapsion. Next up is the latitudinal arch of the foot, which is the arch right here. It's on both sides, but this is the medial side. The posterior tibialis is the most powerful stabilizer. As the tendon contracts, it elevates the arch, locking the midfoot and resists extensive pronation. And then lastly, we have the posterior tibialis muscle. It's deep to the gastrocnemius and soleus. It curves sharply behind the medial malleolus, and the path of the muscle gives the ability to simultaneously plantar flex, invert the foot, and support the arch while controlling pronation during gait. The tendinopathy weakens all of these actions and leads to progressive deformities if left untreated.
Flexion muscles are going to be tibialis anterior extensor digitorum longus, extensor hallucis longus, and peroneus tertius. And then for plantar flexion, for plantar flexion, the muscles are going to be the gastroc, the soleus, flexor digitorum longus, flexor hallucis longus, peroneus longus, and brevis, plantaris, and tibialis posterior. And then why doing these motions matter is because limited dorsiflexion or weak plantar flexion leads to compensation and extra stress on the posterior tibialis during long runs. And next we're going to look at inversion. So the muscles used during inversion are tibialis anterior, tibialis posterior, flexor digitorum longus, and flexor hallucis longus. The eversion muscles are peroneus longus, peroneus brevis, peroneus tertius, and extensor digitorum longus. And these matter because they aid in strengthening the control of pronation and supination while running. Then for toe flexion, the toe flexors are the flexor hallucis longus and flexor digitorum longus. The toe extensors are extensor hallucis longus and extensor digitorum longus. And these matter because they stabilize the arch. Weak toe flexors force the posterior tibialis to work too hard. For single leg balance, Sophia's going to maintain an arch control, and this is important to prevent the medial arch from falling in. The muscles allowing for this are tibialis posterior, peroneus longus, and the intrinsic foot muscles. If the arch collapses during balance, this means that the tibialis posterior is failing to eccentrically control pronation. There will be increased strain with every foot strike. And why this matters is to assess the medial arch control and any compensations that may be occurring at the foot. For a controlled heel raise, the heel should move straight up, the medial arch should rise. Muscles used are the plantar flexors like the gastroc, the soleus, tibialis posterior, peroneus longus and brevis, and the toe flexors. For pronation are going to be tibialis posterior, flexor digitorum longus, and flexor hallucis longus. And the muscles for supination are going to be tibialis posterior, the gastroc, and the soleus muscle. And during walking, the body should eccentrically control pronation during the loading phase and concentrically create supination during push-off. And then all of these motions are important to allow for single leg support while running, providing proper shock absorption, and preventing fatigue.
So this is Forrest Gump, and behind the camera, and we have the lateral hop to balance. So the goal is to strengthen the posterior tibialis in a functional way, playful way, by training it to control inversion, arch integrity, and medial ankle stability during quick changes of direction, similar to what happens during running gait. Forrest hops when I hop laterally and land on my right foot naturally, I want to pronate real forward. But in this exercise, you want to be like soft like a ninja, and you also want to attack the ground with force, very aggressive, because my tender posterior tibialis, and life is like a box of chocolates.
For a mobility and stretching intervention, we're doing a gastrocnemius soleus stretch. The goal is to improve ankle dorsiflexion mobility and reduce compensatory overpronation and decrease strain on the posterior tibialis. Limited dorsiflexion causes runners to collapse into pronation early in stance to compensate. As the foot pronates, the posterior tibialis undergoes excessive eccentric demand, aggravating tendinopathy. Stretching the gastroc with the knee straight and the soleus when you bend the knee increases sagittal plane ankle range and reduces frontal plane compensations. So keep the heels heavy and don't let the arch dump inward. So maintain a subtle lift. The stretch should be in the calf, not the ankle joint.
Hi guys, Forrest Gump here again. So I'm feeling pretty tender in my posterior tib, so I'm gonna be rubbing it really good today. So the posterior tib right behind right here. We're gonna wanna get a ball right here, and we're rubbing it. We are rubbing it. And slow pressure, don't grind. Breathe and relax the foot. And make sure you stay on the muscles, because if you hit the bone, then it's gonna hurt like a little hootie. So tightness around the surrounding tissue, and then also like self-massage, decreasing local sensitivities.
Run, Forrest, run!